Good evening, everyone, and thanks for joining us. Sorry, I'm not dressed up for you today. I just finished procedures, but we'll do a better job next time. For those who are joining us for the first time, we start each webinar by basically giving you a summary of the prior webinars. So those who are interested in the topics can go back and watch those webinars, and we have those posted on YouTube. You can look them up, and Patrick shares those links with you so you can review them. This is the fourth webinar. We started in December, and today we have a wonderful speaker, Dr. Verma, who will be giving the talk today after my 5-minute introduction. Just a reminder of our mission is to make our community the most educated about atrial fibrillation in the nation. Believe it or not, that's our modest mission. The first webinar, we talked about atrial fibrillation, but I highlighted our team, multidisciplinary members of the team, the large team that take care of our patients with atrial fibrillation. And I told you, you will get the opportunity to meet with those members of the team. And today you'll be seeing Dr. Verma, and you'll get the opportunity to ask all the questions you can think of. And also, I have the pleasure of introducing new members of our atrial fibrillation team. If you haven't heard, we just had the cardiology group from West Florida Hospital join our cardiology group, and we are lucky to have Dr. Branco here and Dr. Farhad Mahmoud, both our electrophysiologists, are joining us and joining our team. So our team just got better and bigger, and you will have all the experience and expertise you need to be taking care of you or any patients with atrial fibrillation. Again, back to our first webinar, we discussed that atrial fibrillation is a loss of the atrial contraction, the organized form of atrial contraction, the top chambers of the heart, resulting in disorganized activity. Basically, it's an electrical problem, results in mechanical issues and increased risk of forming clots in the top chamber of the heart that can cause potentially a stroke. And we discussed options to reduce the risk of stroke by taking pills. And for those who are not good candidates to take the pills because of increased risk of bleeding or recurrent bleeding, then we have non-pharmacologic options or options that does not include medications, including the Watchman device. Then in atrial fibrillation webinar number 2 in January, we discussed antiarrhythmics. And we distinguish between paroxysmal atrial fibrillation episodes, where atrial fibrillation comes and goes on its own, to persistent atrial fibrillation, where the episode would last until we actually terminate it, and usually by cardioversion using medications or electrical shocks. And then we discussed permanent atrial fibrillation, when atrial fibrillation becomes a fact that we're going to live with and no further options left to get back in rhythm. We explained the electrical shock and how it's applied and what it means. We discussed the difference between transthoracic echocardiogram and transesophageal echocardiogram. And we also discussed the 2 main classes of rhythm medications, class 1 and class 3. And we discussed that class 1 would be used in patients with healthy hearts, and class 3 are usually safe in patients with sick hearts, meaning those patients with prior history of heart failure, heart attacks, very weak or very thick heart muscle. And also we ended that webinar by saying, no matter how good antiarrhythmic medications are, atrial fibrillation ablation is better in maintaining sinus rhythm. The last webinar last month, we discussed catheter ablation at length, and we discussed the basis for catheter ablation, and that is to create a full thickness scar in the heart muscle in the top chambers, in the atrial chamber muscle, to prevent the electrical signal from going across and creating those electrical circuits responsible for atrial fibrillation. And that was the basis for the first surgical ablation procedure performed by Dr. James Cox in 1987, creating those scars and surgical scars in the top chambers of the heart, creating barriers against those circuits going around and restoring sinus rhythm. Then we discussed an easier and less invasive way of achieving the same lines of scars using catheters that are used with minimally invasive procedure through the groin, with the catheter going inside the heart, and the point of contact between the catheter tip and inside the heart an energy is applied, we call it radiofrequency energy, and the contact point between the tip of the catheter and the tissue of the heart is scarred down, and the goal is to create full thickness lesion and full thickness scar to stop those electrical circuits from going around. And we also discussed that the targets for our ablation is usually within or around the opening of the blood vessels that bring the blood from the lungs to the left top chamber of the heart. We call them the pulmonary veins. Why? Because most of those veins, or most of the triggers for atrial fibrillation, come from those areas. And that is basically the main target with our atrial fibrillation procedure. And we discussed paroxysmal atrial fibrillation. Usually you have few triggers, and the ablation lesions are usually limited with high success rate. But if we wait, other circuits develop and becomes much harder to achieve success with one ablation, with high likelihood of those circuits coming back and causing more trouble. And this is basically a schematic representation of the lesions we create in order to achieve successful ablation. That could be limited to 2 circles around the pulmonary veins, additional lines, different areas, depending on how long this patient been in atrial fibrillation and how many circuits we have to deal with. And we discussed what it is like to perform the procedure, how it is performed, and all the imaging modalities we use to create those lesions, turning those areas in the pulmonary veins into silent, electrically silent areas. And we discussed that red is dead, purple is alive. And this is an example we gave how much more ablation you need to do and how many more lesions you have to do in those patients who are not attended to early enough. And that was the basis for our recommendations to be careful to detect and diagnose atrial fibrillation early, and earlier intervention provide higher chance of success. And we discussed the option of cryoablation using freezing, or radiofrequency catheter ablation using heat to achieve the same goal. And we discussed the different studies. Each one of them showed ablation to be much higher success rate relative to anti-arrhythmic medications, maintaining sinus rhythm. And we also ended by discussion regarding the relatively low complication rates with atrial fibrillation procedure, not limited to stroke, heart attack, or death, and we discussed all those details. And that basically how we ended last webinar, and we discussed that it is atrial fibrillation that is recommended to be a first line of therapy, or when rhythm medications fail to maintain sinus rhythm. And now it's my pleasure to introduce my partner, my friend, and the guy I would love to listen to all the time to learn from, Dr. Verma. And this is his brief bio. Basically, he is our current director of the Cardiac Electrophysiology Laboratory, and he did his electrophysiology fellowship at Yale, and he joined us in 2000. And we've been together. I joined this group in '99, and he joined us in 2000. And it's been a wonderful partnership. Dr. Verma has amazing interest in improving the quality of care for our patients, and has been a great representation for our institution and for our community, not only at the national level, but also at the international level. He kept his academic passion alive, publishing and presenting at many national and international conferences. And as I mentioned during our recent cardiovascular symposium, we have annual one, and I introduced him and I said he is our ambassador at the national and the international level. So it's really my great pleasure to introduce to you Dr. Verma, who will be talking to us further about atrial fibrillation and educating all of us.
Good evening, everyone. Thank you for taking the time to join us for this webinar. A very special thanks to Patrick, who does a lot of work behind the scenes to make this happen. My talk today is about achieving ultimate safety with AF ablation. And I assume that either some of you have had ablations already or are dealing with atrial fibrillation and would like to learn more about this. we're going to focus on, how we approach safety and how we try to learn from our experiences and other people's experiences and make this procedure as safe as possible for our patients. So I will be spending some time discussing safety in general, and then I want to introduce and discuss some of the technologies that we use so that you all may understand and have more confidence in the technologies, as you will realize that many of these technologies are very highly developed, and they're not just first generation technologies. They have come a long way. Each and every aspect of what we do has been developed. Now AF ablation has been around almost 25, 30 years. So you can imagine the amount of advances that have occurred. Can we more advanced? Okay. So I hope we can get you to a level of confidence where this never happens to you. It's never happened to us yet, where we've had a patient on the table get up and run off as we're trying to start the procedure. So here, apparently, they don't have a level of confidence. And when the doctor yells clear, the patient is getting up and heading out. So how safe is an ablation procedure? And this chart here is basically only talking about atrial fibrillation ablation. And you can imagine there's a very long list of things that could happen. And this data is from a Medicare database where they go back and look at thousands of patients, and they look at the numbers and see what all could have happened. And I will, at the end of this talk, show you our own experience and how we look compared to this Medicare database. So if they add up all the potential complications, which include tamponade, stroke, transient ischemic attack, heart block, pericarditis, etc., and I'll explain these in detail, they had about a 3.36% frequency of complications. And now these are major and minor. So these aren't all major complications. Now, there are some others that are not listed there, which can also happen, which are chest pain, pericarditis, heart block requiring permanent pacemaker, gastroparesis, lung injury, and these are things I'll talk about in some detail. So there's a lot of lessons to be learned from other industries that deal with, things that obviously almost any industry is prone to situations where harm might occur. And there has to be a culture in the industry to avoid such events. And safety has to be first, and there should be no shortcuts taken. As I was reviewing what is the safety culture, it applies to almost every industry, as I said, and people have learned lessons sometimes the hard way. So there have been major accidents in nuclear power, Chernobyl, the space exploration, Challenger and Columbia, chemical leaks, oil, gas, aviation, of course, and all these industries. When you look at how safety is approached, there's some things that are very common in how they went back and looked at the events and made themselves better from those. What do we do here? We have a system. First of all, you have to admit that if some problem occurs, we have to first of all admit it, and then go back and fact find. And we have to do a root cause analysis and see where was there an error made? Was this preventable? What changes can we make in our practice going forward? And as you do that over and over again, eventually you'll get to a point where you can predict almost every potential risk and find ways around it. So you don't go down that path where you might end up in that situation. In our culture, we have our physicians self-report. So we have a system, a database that keeps track of any problems that could have occurred or problems that occurred. We have a database, and anytime something happens, the physician reports that to the database, and we keep track of it. If there's a trend emerging, then we go back and deal with it, figure out why that happened and what we're doing different, what we need to do different. The team members who are involved in these cases, they are all expected to tell us if they have any ways to either improve things or make things safer. I'm proud to say that Baptist is one of the few hospitals in this area that monitors our outcomes. We very carefully monitor the results and the safety protocols. And if there's any blip outside of the what could be expected, then it is brought to our attention. We look at it and address that issue. And of course, we have our patients telling us, giving us feedback. Now, what are the barriers to perfection? Perfection would mean 0% complication rate and 100% success rate. And that's a tough ask in medicine. There could be medical errors, which obviously we do our best to avoid. There are limits to technology. There's maybe only so much that can be done with an ablation catheter, only so much monitoring that can be done. There are unexpected events. Now, we don't, as you get more experience, very little is unexpected. So if we go into a case knowing that there's a high risk of this or that, some other event happening, then usually it's not unexpected. So this is happening less and less. There are, of course, patient issues, some comorbidities. Do patients have a bleeding tendency already? Do they have kidney problems? Do they have diabetes? Those things also add up and increase the risk sometimes. And we will usually counsel the patient before we go into a procedure like that. Expanding the patient population who can receive therapy. Now, if we chose to just say, we're only going to do this procedure for a patient who is perfectly healthy otherwise, who may be 30 years old and only has atrial fibrillation, and that's the only patient we're going to work on, then yes, it's much easier to have a 0% complication rate and perfect safety. But on the other hand, the patients who need this generally have other comorbidities. So that's something we have to deal with and figure out ways to make it safest for everybody. Now, what is involved in an AFib ablation? I think if you've heard the previous webinars, I think you should have some idea what is involved. Patients are generally, they go under general anesthesia, which means they go to sleep, the endotracheal tube is passed into the trachea. We then perform a transesophageal echo where the ultrasound probe is passed through the mouth into the esophagus to look at the heart, make sure there's no blood clots inside the heart. We used to place a Foley catheter for urinary drainage. Now I put an X there because we no longer do that. Majority of our cases are faster. We don't have a situation where the patient is incapacitated for several hours at a time. And so that is something that can be avoided, and everything you can do less of leads to less risk of complications in that area. We used to place a catheter inside the artery to monitor the blood pressure. We don't do that anymore. We then perform vein punctures to introduce catheters into the heart. We then perform a transeptal puncture of the atrial wall, and I think I'll show you a picture of that. We then do mapping and ablation. We monitor the organs that are immediately outside the heart, so the esophagus, the phrenic nerve. And of course, there's a potential for problems even occurring after the procedure is completed. So it doesn't just end there. There's a risk of what if somebody starts bleeding afterwards? What if they have low blood pressure, they feel dizzy, they have pain? So there's ongoing things that can happen that we have to anticipate and plan for. Now this picture is a little fuzzy, but it's the best I could find. The catheters are introduced from the leg, usually just the right leg. They go up into the big vein, the inferior vena cava, and then enter the heart. And now when we enter the heart, when I talked about transeptal puncture, it means that we have to puncture this thin wall between the right atrium and the left atrium. We use a special needle for that. The needle is positioned on the wall, and then we push it through. And then that puts our catheters inside the left atrium where we do the rest of the work. Now this is a picture of the left atrium. Now we've entered the left atrium, and as Dr. Al-Sheikh had shown you earlier, we perform ablations. So these dots are ablation lesions. We use a special three-dimensional mapping system that is extremely accurate, and it gets us down to, it's accurate down to 1 millimeter. So there's not a whole lot of room for error here. And once we've entered the atrium, we know precisely where we are. And I show this picture because if you look closely, you will see where the vein is and where the lesions are placed. So this is the opening of the vein, and the lesions are placed a little bit away to stay away from the opening of the vein. The reason for that is when this procedure was first started, this was not known, and the lesions were being placed very close to the vein, resulting in later some stricture or narrowing of the veins. So that's a problem called pulmonary vein stenosis. So even today, if you read about complications of AF ablation, that sometimes shows up at the top of the list, but it doesn't happen anymore because almost everybody should be ablating away from the opening of the vein. So this is another picture that Dr. Al-Sheikh also showed. Similarly, once the ablation is done, we can check the voltages in those veins. They are red. That means there's no more electrical signal in those veins. And the back wall of the heart is purple, meaning that that has normal electrical signals. The mapping systems have improved significantly. So even within the last year, we now have mapping systems that are more accurate. They give us more data. They do better analysis, which all leads to less ablation being required to fix the same problem. So this is a picture of, again, just the left atrium, and we can turn the image around. We can see exactly where our lesions are. We can look for any gaps in those dots. Sometimes there's a gap or two and we have to go back and touch it up. So this is all done during the procedure. And this picture shows you, again, this is my effort to give you some more confidence in how these procedures are done and how much accuracy there is. So when you go in for one of these, you know exactly that, you know, there's a high level of confidence in what we're doing. And so this will show you how the electrical currents are traveling through the left atrium. So as you can see, there is a flow of current coming there. It comes from the bottom. It goes through this little gap here and then goes to the top and then goes around. So we call this re-entry, meaning that the current is just spinning around in a re-entrant circuit. In this case, the computer also tells us where the slow conduction is. So it's not just looping around, but there's a potential target for an ablation, which is right here where the blue meets the red. And so a couple of lesions here is all it took to fix this, what would have been otherwise an atrial flutter with a heart rate at 300 beats a minute in the upper chamber. So a couple of dots here of ablation would fix that. Now here's a picture. This is probably from 20 years ago, but this shows what the problem occurred in the past before we had three-dimensional mapping. And before three-dimensional mapping, we would, well, I wasn't around then, but the people who did this, they would go into the vein, find those bad signals and ablate them without really knowing how far into the vein they were. And you can see here that this has resulted in a marked narrowing of this vein. This is called a pulmonary vein stenosis. Again, a very old complication. And I call it old because in today's day and age, it should not happen. Okay, so how have these ablation catheters evolved? they have come a long way. The standard RF ablation catheter used to be, and still is, we still have this. It was basically a electrode tip that heated up and caused the ablation. And then somebody figured out that let's make it bigger. So they made it 8 millimeters or 10 millimeters, double the size of it. And then somebody figured out that part of the problem was just heating the tissue alone isn't good enough, because when you heat the tissue very rapidly, what you do is you create an area of char on the tip of on the surface of the heart. So what you actually have to do is you have to cool it as you're sending the RF energy in. So what that lets you do is create a much thicker lesion. So the lesion is deeper and the surface is not eroded with just pure heat. So these are called cool catheters. So not only are they heating the tissue, applying energy that is penetrating the heart muscle, but they're keeping the surface of the heart cool, so it doesn't result in a char or a perforation. So that's an advance that occurred. So there's different ways to irrigate the catheters. You can irrigate it internally, which is closed irrigation. You can do open irrigation, where the irrigation is now coming out of the catheter and actually the water, the saline is touching the heart. And so these are the kind of things that have been improved over the past years. And more recently, the biggest improvement is contact force sensing, which means that when you're touching the heart muscle, it is no longer just the doctor who's feeling that heart, that catheter on the heart. It's the catheter itself has a sensor that is telling you how much force you're applying. Are you applying 5 grams, 10 grams? Or are you applying too much force and you need to back off a little bit? So that has improved the safety quite a bit. So this is another evolving dilemma we have. Do you think I should give him 50 or 100? So different situations require different amounts of energy. And we do have situations where we might do 50 or 50 watts on one side of the heart. We might do 20 watts on the other side, depending on what the location is. Now, this is just a close-up picture of that ablation catheter that we are currently using. So the ablation catheter there's a tremendous amount of technology in this. This is the tip of it. If you look closely, you see these little tiny holes. This is where the saline infusion seeps out of the catheter and washes it off as it's heating the tissue. There is let's go back. There is a spring mechanism in here which keeps it from being too stiff, so it can bend as it's touching the heart. It has a contact force sensor, so it tells us exactly how much force is being applied. And then we can move this different ways. It's called bidirectional. So you can go left or right with it, and you can turn it around and know exactly where you are based on the mapping system tracking it. Another technology we use during these cases is a intracardiac echo. So this also, as you can see, it's a catheter. We control it with this handle. The catheter is introduced into the heart. At the very tip of it is an ultrasound. So this is called intracardiac ultrasound, where the ultrasound machine is actually inside the heart. And this lets us see the heart in this fashion. So when we're doing that transseptal puncture, that some patients read about it, they do ask, ask about the transseptal puncture, because it's a somewhat worrisome procedure if you haven't, done it. But we have a very high level of accuracy while doing a transseptal puncture. The ultrasound machine is telling us exactly where the needle is. You can see that needle is pushing on that wall. We call it tenting, so it's pushing the wall. And we know exactly we're in the right place here. We can put that needle through. But if we were in the wrong place, let's say we're in the thick part of the septum, it's not something we would take. That would not be the right position. So the risk of problems during a transseptal puncture is extremely low because of the presence of this ultrasound catheter. They have looked at ultrasound catheters and shown that the risk of perforating the heart is much lower when you use the ultrasound versus when you don't. There are some other interesting observations that were made. So one of them being that females tend to be at slightly higher risk of perforation. I assume that's because of body mass being lower, generally females being smaller in size and the tissues maybe being more fragile. Alternatively, if somebody was more obese, that also results in increased risk of perforation. Prior cardiac surgery tends to be somewhat protective. And this is another fascinating observation. And this is because after cardiac surgery, there's some scarring that occurs around the heart muscle that protects it, possibly from bleeding. And it also closes off that sac that's around the heart, the pericardial space. So it's kind of stuck to the heart, provides a second layer of, I guess, a backup layer for the heart so it doesn't bleed. Now, also just adding that intracardiac echo also reduces the amount of X-ray that is needed because it replaces we can do the imaging with the ultrasound instead of X-ray. Some things that we find are always of concern for us during an ablation. We have to be very careful with a couple of organs that surround the heart. So the esophagus sits right behind the heart. And when we're ablating the backside of the heart, we are extra careful looking at the esophagus. We want to know where the outline of the esophagus is, so we don't cause heat to enter the wall of the esophagus, cause damage to it. And this is how it might look on a three-dimensional map. So this is again looking at the heart from the back, similar view to what I showed you earlier. The esophagus sits right in the back. So when you apply heat from the inside of the heart to the back wall, you could potentially cause that to injure the esophagus. What happens with esophageal injury? You can develop ulcers. So in this case, you could probably see the outline of this. This is a case that was presented elsewhere where they had done endoscopy later on, and they found that there was a patch of possibly a thermal injury to the esophagus. We have to be careful with other things that are outside the heart. So organs like the esophagus, then there's the phrenic nerve. The phrenic nerve is what causes the diaphragm to move up and down. And there's two phrenic nerves, one on the right, one on the left. When we're applying heat to the inside of the heart, if you don't know where the phrenic nerve is, you're trying to ablate heart tissue, but then you could end up damaging the nerve that runs on the outside. So we do things like phrenic nerve monitoring. We check the function of the nerve. We check the diaphragm. We course we have ways to find where the nerve is and mark its location before we're ablating. This is what could happen if the phrenic nerve does get damaged. This is an X-ray image. This is before, where the diaphragm on the right side is normal, the left side is normal. And in this patient, there is a paralysis of the diaphragm being elevated. And these are pictures taken from the internet, so these are not our patients. Some creative things that can be done are to protect the phrenic nerve, or to place special balloons inside the atrium or inside the chest to protect the phrenic nerve. These are not things that we would normally do for an ablation for atrial fibrillation. I think this is for very special cases, but there are some very creative ways that people have gone about this to increase the safety. More common things we worry about is things like pericardial effusion, and we call it tamponade. So this is a picture of the heart. Right outside the heart, there's a little sac called the pericardial space, which is pictured here in the black line. If the patient starts bleeding, let's say from an ablation, or the force was too high, or the heart muscle starts bleeding on the outside, then the blood starts collecting in this sac that is outside the heart. And that sac is not very flexible. So once it starts filling up with blood, the heart itself starts getting compressed, meaning that it can no longer do its job of pumping blood, and the blood pressure drops. In these cases, then we have to place a drain in the chest to remove that blood. It can be recirculated back to the patient, and then it almost always stops after a few minutes if this happens. This is how it might look on an ultrasound image. So that's the heart. You can see how it's getting a little compressed here. This is big spaces where the blood has collected. And in these cases, a drain would solve that problem. Now, urinary tract infections, it's well known that patients who have a Foley catheter placed for any reason, they could be in the hospital for a lung infection or for something else. And if a urinary catheter is placed, there is a definite risk of getting infections. So we have in our practice almost completely gotten rid of these catheters. So they're not put in unless we do have some patients who will ask us and request a Foley catheter because they have urinary problems and they need that. So when it's requested, or we will obviously honor that request, but most of the time our preference is not to place the catheters. So because of that, the risk of infections has almost gone down to zero. Getting a urinary tract infection. We do, however, see some people develop urinary retention. So meaning that after the procedure is done, they are not able to void on their own. And that's not uncommon after anesthesia. So anesthesia might have this relaxing effect on the muscles or a slowing effect on the muscles of the bladder, and then result in a situation where people need a little help afterwards. So might mean a catheter put in, or they have to have a temporary catheter called a straight cath just for once or twice before they can get going on their own. Now, I will talk about vascular complications. Vascular complications means complications of the blood vessels. And we've had a very special interest in this. In the past, it has been known that when you do these ablation procedures, it's not always the heart that causes the problem. It's usually the puncture site in the groin. So you might have a perfectly well done ablation and the heart's absolutely fine, but then patients are having problems because they're bleeding in the groin. They're having to lay in bed for 6 hours. Sometimes after the 6-hour bed rest is done, they start bleeding again. And so it can be very, very problematic. There can be more serious complications where the vessels get damaged and people need to have surgery done by a vascular surgeon to repair that. So in the past few years, there have been some major advances, and we published this last year at the Heart Rhythm Society meeting, which is our international meeting, where we showed the safety of using these special devices. One is a special stitch that goes inside the groin and closes up that puncture site right away. And the other is another way to put a little collagen plug where the puncture site is. So both work really well. And we're probably one of the few practices where we have adopted this as a standard, and almost every patient will get this. So the risk of bleeding is almost negligible afterwards. We also have gone to using ultrasound to find the vein. So this is ultrasound image of the groin where we're starting the procedure, and we know exactly where the vein is, where the artery is. We use a special needle under guidance to enter that vein. So this kind of precision is what makes the procedure more safer. You know, these are all the little things that go into making a safe procedure. So knowing exactly where you are, how much force is being used, you know, how we're approaching every little aspect of this. And this is another article we published recently where we showed this is how many catheters were being put in. Picture of a groin. This is how many catheters were being put in 2018. So we had 1 in the artery, there were 4 in the vein. This is to let us do the ablation procedure. Like I said, we then got rid of that arterial catheter, so we don't do that anymore. And then we got down to 3 of these in the vein. And this is how many different pieces of equipment are needed. So we need the ultrasound catheter, a mapping catheter, ablation catheter. And then finally, we've gone to this approach. We only have 2 punctures in the vein. And as you can imagine, this is a very big difference in how much safer the procedure is. So there's less punctures, there's ultrasound used, and at the end we put those sutures in or a collagen, and that has virtually eliminated the risk of any bleeding complications. So this is kind of a picture of how that suture device works. It's kind of complicated, but has this little mechanism by which you can enter the vein, and it leaves a little stitch there. Some centers are using this, what's called a figure of 8, which I don't like. I think because it's not scientifically, it just doesn't add up in my mind. So what they do is they take a big suture and they tie it around where the veins, where those catheters are, and they kind of cinch it together. Some centers do this, we don't. I think it's far better to use a closure device. So this is how it looks as we're starting. There's 3 wires that are entering the vein. This is an older picture. And now we would have only 2. But right after we're done, while the patient is still asleep, we have put those sutures in, and you can see there's no bleeding. And we have closed that groin puncture sites immediately. So once the patient wakes up, they won't have anything in their groin that needs to be pulled later on. Patients who've had ablations in the past years have always remembered that. I think they remember the sheets coming out a few hours later. And I think that's sometimes more traumatic because somebody's holding pressure for 30 minutes. And so that doesn't happen anymore. Patients wake up, they're perfectly, I think, without any tubes left. And usually it's a 2-hour bed rest, and then you can get up and go home after a few hours. So we are proud to say pioneering some of these things where we are adopting this, what we call early ambulation and same-day discharge. It came at an interesting time. We started doing this a couple of years ago, and then COVID happened. And then at first, there wasn't a whole lot of centers that cared about this. And then suddenly everybody cared, because with COVID, the patients don't want to stay in the hospital. The hospitals didn't have room to keep them. And it was a perfect sort of coming together of this technology and this experience we had already. So that has been very useful. I think it's made the procedure a lot more acceptable to many people. And of course, there are situations where patients have to be kept overnight, and there are situations where, you know, we want to monitor them. And of course, those are exceptions, but the vast majority of our patients are able to get up and go after 4 hours. So we're glad to share these techniques with other centers so they can also learn from us. And we're proud to present this. This is our last year's data, which we have submitted for the international meeting this year, the heart rhythm meeting, where we had 0 major vascular complications. So major means patients who had problems with the groin that required surgery, blood transfusion, or were otherwise life-threatening or dangerous. So there were 0 of those in last year, which is pretty incredible, because that's not, I don't think anybody's ever shown that with AFib ablation. So it's a lot of, I think, different things, but so how did we do last year? And I got this data today and trying to put it together. So we had 2 patients who required a pericardial drain. And this is roughly 600 plus cases that we did last year. Nobody had a stroke. 1 patient had a transient ischemic attack, which is a mini stroke, which means that they had a defect with their speech, which resolved after a few hours. It did not result in any long-term issues. AV block means their heart's natural electrical system was damaged, and nobody had that happen. Pericarditis means that they had some chest discomfort, possibly for a couple of weeks, that required special medications, anti-inflammatories, etc. Nobody had sepsis. One person, actually, this should be one person had a phrenic nerve injury, which was transient, and transient means it resolved after a few weeks. Of the vascular complications, I already told you we had 0 major vascular complications, but one patient had a minor complication, meaning that they had a hematoma develop, bleeding under the skin, which did not require surgery or blood transfusion or other things. Overall, the real bad complications like bleeding inside the chest, bleeding in the abdomen, and some of these other things, there were 0 of those. So adding all these up, our major vascular complication, our major complication rate total was 0.5%, which is less than half of 1%, which is half of 1%, and versus about 5%, which has been reported. So, which is roughly about 1/10 of what national levels are, as far as complications are concerned. So, in summary, we are, I think, you know, we are keeping up with the technology. We are doing everything we possibly can to keep this procedure safe. And we're hoping to get to a level where there's 0 complications. But I hope you understand more about all this, and you know, any questions, we can certainly glad to answer those for you.